Chapter of Physicians for a National Healthcare Program. It's a nonprofit, nonpartisan research and education organization in support of providing an improved form of Medicare to all Americans. After practicing family medicine for 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. He's currently an assistant professor of clinical medicine at Washington University in St. Louis, Missouri, and volunteers in a variety of safety net clinics and other nonprofits across the St. Louis area. And he also serves as the interim president of Consumers Council of Missouri. He received his medical degree at the University of Illinois in Chicago in 1979 and completed his family medicine residency and a fellowship in family medicine education at Michigan State University in 1982. Dr. Weisbart is a national speaker, so we are lucky to get him here tonight, with several articles published in both national medical journals and local media regarding the healthcare needs of the uninsured. So with that, Ed, I'm going to turn it on to you.
There we go. I'll bet you can hear me better now. Thanks, Maureen. Thanks for inviting me. Thanks for setting this up. And I'm looking forward to this and to Dennis and comments and to the general discussion. So thanks. It may seem a little bit funny to be talking about Medicare for All right now when Missouri has got so many issues in flames, on fire. You know, I think a lot of us are really intensely focused on what Dennis will be talking about Medicaid expansion. But I'm here to tell you that the issue of single payer Medicare for all is marching forward with tremendous progress. And I'm going to show you some stuff about that. So what I'm planning on talking about is what is Medicare for all? You know, why should we all care about it? How would it work a bit? Then some of the exciting things that have changed in the new bill that got submitted a month or two ago from Representative Jayapal. So we'll show you how it's even improved over improved. And then we'll talk a bit about the public option. So full disclosure, as Maureen told you, I chair the Missouri chapter of Physicians for a National Health Program. And our group is really focused on single payer Medicare for all. I have a somewhat adjacent point of view about the public option. So when we're talking about that, that's my point of view more so than our organizations. But the progress has been incredible, more than you might have noticed. So the medical students, if you need inspiration about the future, just go talk to some med students. These folks are just phenomenal. And medical students held a large demonstration a couple of years ago in front of the annual American Medical Association meeting. And who cares about a demonstration? Well, because most of us think directly because of the medical students convening on the AMA meeting. The AMA, for the first time ever, actually left the lobbying group that has been so aggressively arguing against Medicare for all. So the AMA was one of the strongest members, and in direct response to medical student advocacy, they left that. So hooray for us. And one of the two largest physician organizations, the American College of Physicians, sort of the AMA for general internal medicine, came out last year and endorsed single payer Medicare for all, again for the first time ever, is one of the very reasonable and good ways forward. So that was a huge step forward. And then most recently, of course, just a couple months ago or so, Representative Jayapal submitted the 2021 update to the Medicare for all bill. The legislation proposing single payer Medicare for all has been in Congress for, 15, 17 years or so, and gaining in popularity and sponsors gradually, bit by bit. But what you may not have noticed is that the new submission from Representative Jayapal this time has more original co-sponsors than the bill has ever had. A majority of the Democrats in the House were yet to get any Republicans, but more than it's ever had, and important new people co-sponsoring it. So this, for the first time, it's co-sponsored by the chairs of some of the really important jurisdictional committees on it. So right out of the box, we've been promised meaningful jurisdictional level hearings. That's the first time. And the bill has been improved in important ways. So more equity, more directly addressing the things you can see here. Senator Sanders is going to be submitting his bill in the Senate any day, any week. We don't know when, but so I have no comments on that because we haven't seen it yet. But here's the problem that we're facing. You know, you're probably familiar with this. There's life expectancy on the left and what we spend on the right. As you probably have seen, in general, the good news is, in general, the more a country spends on healthcare, the longer their people live. And this is corrected for, international dollar issues. So in general, the more, but it sort of flattens out. There's a limit to what you should spend. This chart does not include the United States. There's the USA. So we're not even on the curve, not even on the curve. And what that means is that if our system performed as well as sort of the global norm, we should all be living 5 years longer than we do. So the dysfunction of our system shortens our lives by 5 years. Or if you don't care about living 5 years longer, for what we're getting, if it's just the healthcare system, we should be spending $6,000 less per year. So we're not getting a good deal. And it's really complicated. So Uwe Reinhardt, who died about, I think, 4 years ago now, made this statement about how to pick a healthcare plan, a health insurance plan in America. And he said there's a few steps. He said the first step is decide what diseases you and your family are going to have in the coming year. Okay, I'll do that, right? And then step two is identify who the best physicians and hospitals are to treat those diseases. Okay. Step three, of course, is to pick your insurance product that covers those diseases, those hospitals and doctors. That's how you should do it. Of course, if there isn't an insurance product like that, Uwe said, go back to step one and pick new diseases. So I heard him say this, I don't know, 10 years, 12 years ago or so, and I just thought it was kind of cute. And I put it in my someplace in my brain. And then this weekend, I was helping my sister-in-law, who has had the first opportunity she's had in a long time to be able to get health insurance on the marketplace. So I was helping her pick a plan, and it's really a mess. So she has some illnesses, which I have her permission to mention to you. She has some illnesses, and she has 4 main physicians. She has a gastroenterologist, a rheumatologist, a neurologist, and a gynecologist. And it turns out when you go on the marketplace where she lives in Florida, there isn't a single insurance company. I looked at like 35 of them, and that's what everything they offered. And there isn't a single insurer in where she lives that includes more than one of her doctors. So my conversation with her literally was Uwe Reinhardt's joke. My conversation with her was, well, in the next 12 months, you think you're gonna have more problems with, GI problems or more problems with your joints and stuff and skin problems? We had to pick, we tried to predict which one of her 4 main doctors we really wanted to make sure was in her network for her insurance. And then the others she would either not see or pay retail or whatever. So that's insane. You shouldn't have to do that. Is Medicare for All actually any better? Is Medicare any better? Well, it turns out all 4 of her doctors are in take Medicare. So yeah, Medicare would be a heck of a lot better. So there's Harry Truman was the first Medicare member, and just there's 3 things about Medicare that I don't think people appreciate enough that I want to sort of point out, which is why I think this is the way to build a universal healthcare system. The first is what we were just talking about. Medicare is the best way at putting you in control of your healthcare choices. A friend of mine, Lefty O'Rear, before he passed away, said it was like being let out of jail. He got to pick his doctors and healthcare. It's like being let out of jail. It puts you in control. It eliminates a lot of the waste that explains the chart that we showed you about what we spend. And lastly, it makes us actually a lot healthier and live longer. So let me maybe show you some information about that. In terms of putting you in control of your healthcare, it turns out that 93% of adult medicine physicians accept Medicare across the entire United States. Across the entire United States. So if you have some commercial, so-called private insurance in Missouri, and you go traveling to Colorado, there probably isn't a Colorado physician in your Missouri insurance company. So this lets you go anywhere in the country. The vast majority of physicians in almost every hospital accept it. So you get to decide who you want to take care of you. It's also incredibly efficient. It's big government, but it's really efficient. Turns out government can do some things really well. So here's the overhead of the larger insurance companies. And Any of my charts that have numbers, as this will, and the last one did, there's a reference on the bottom left of the public domain site. So the overhead SEC filings for the larger insurance companies is, let's say, 15%. You know, they have to pay all sorts of things that Medicare, with its 2% overhead, doesn't have to do. So the larger insurance companies, they have to pay for television ads, which we all see. They pay for sales and marketing and massively redundant insurance or information systems and all kinds of call centers to tell you, no, you can't do these things, and appeals and stuff. Almost none of that happens within Medicare, which is why it's just spends a lot less money on overhead and such. So 15%, and that's the smaller part of the overhead difference. It turns out that the insurance companies hide a lot of their overhead in hospitals, where we have massive departments of billing and insurance functions. Nobody like that in Canada, for example. With doctors' offices have about $100,000 of staff managing the insurance relationship. Doctors' offices in Canada, about $20,000 to $25,000 worth of that. United States, about 100,000. Hospitals in the United States have one person employed for every hospital bed, just about 900,000 beds, nearly 900,000 billing people in United States hospitals. Canada, it's more like 1 to 100 or something like that. There's 750 hospital beds in Toronto General, and they have 12 billing people. So we spend a lot of money just propping up this complicated insurance model. And the reason that we do it is to keep the cost of healthcare down. That's what we claim to be able to do. Well, it turns out, if you look back over the last 10 years or so, the commercial insurance industry has had a per person increase in spending by more than 50%, whereas Medicare has kept that down to less than half of that. So the commercial insurance industry fails at the one thing they claim is their justification, keeping the cost of healthcare down. And Medicare, on the other hand, is phenomenally good at that. But most importantly to me as a physician, Medicare makes us actually live longer. So you knew before you logged on to this call that Americans live on average 3 or 4 years shorter than most people do in other countries. Our lives are cut short by 3 or 4 years than they would compared to what they would be in any other modern nation. Here's that information by age group. So on the left-hand side, you see children. On the right-hand side, you see our most senior people. And here's us compared to 17 other countries by age. And as you can see, we are the bottom of the chart on mortality rates or life expectancy. We're the worst out of 17, despite spending twice as much. We're the worst, you knew that, until we turn 65. And that's when the magic happens. And country by country and year by year, we climb to literally the best in the modern world. So that means that we should be very proud. We in the United States have many of the world's best doctors and hospitals and nurses and pharmacists and all that. We just don't let everybody into the system. Single payer Medicare for all, of course, would address that. And it's a pretty simple concept. It basically says improve Medicare, meaning pay for all medically necessary care. And here's a partial list. A lot of the things on this little list that I showed you are not covered probably by your insurance that you have today, unless you don't have this because it doesn't exist yet. So it would cover all of these things. And it would be free at the point of service. So no more copays, no more deductibles. We know that copays simply succeed by keeping people away from healthcare. I mean, that's not a good thing to do. So free at the point of care. And if you did that, if you improved the benefits, so it covered drugs and all those things, and got rid of the copays and deductibles, well, then if you're in Medicare or in Medicare for all, there would be no reason to look for a supplement or join Medicare Advantage or any of these crazy, you would just have health insurance. You would just have health insurance because you live here. It would cover everything that you need. You wouldn't have to worry about bankruptcy. You wouldn't have to worry about copays and deductibles. It would cover everything. You wouldn't have to go shopping for a Medigap or whatever. You'd be done. You could go back to just thinking about the rest of your life. And it would be funded not through premiums. You know, a $10,000 premium is unaffordable, unreachable for somebody making even $15 an hour, whereas a $10,000 premium for somebody making $100,000 or $1 million a year $10,000 premium becomes, not on their radar. So that's not the way to fund a public good, a common good. So instead, Medicare for All would be funded through an equitable tax model, as we do other common goods like most schools or roads or the military or things like that. And then the second feature, so the first thing is improving Medicare, not Medicare as it is today, but an improved form of Medicare in these ways. And the second thing is just leave nobody out of this. Leave nobody out of this. Include everybody who resides here, regardless of their age or what have you. Include people who are residents, legal residents, or people who are here on other kinds of circumstances. And we've sort of recognized that covering everybody for COVID vaccines makes sense because I can catch COVID from you. We're not quite as clear as a country that your diabetes affects me, but it really does. Your diabetes does affect me. If you can't control your diabetes, well, then you're not going to work as effectively, and you're going to wind up, the employment situation is worse. You might read about disability. There's all kinds of problems that happen. We are all in this together. And so the proposal is that everybody who resides in the United States be included in this system. Now, that doesn't necessarily mean you can cross the border and immediately have access. The bills charge the Secretary of HHS with defining residency, so there would be some parameters around that. But basically, everybody who lives here would be covered, and you'd be covered for your life. You wouldn't have to work from cradle to grave. You wouldn't have to worry about it. You wouldn't have to worry about pre-existing conditions. This uniquely American concept. If you're sick, if you're healthy, you would have this insurance. And as I said, you'd have free choice of practically any doctor and hospital. The economics are compelling, and I'm not going to do a deep dive, just give you 3 points about the economics. The first is that there have been dozens of studies that have said that, the savings, of course, there would be new expenses. Every study, of course, recognizes new expenses, but there would also be new savings. And the new expenses are the same or smaller than the new savings. So every one of the studies, dozens, says that the savings are at least as big, if not bigger, than the new expenses. Every one of the appropriate studies. There's two that are kind of goofy and make crazy assumptions, but dozens of studies have said this, to the point that hundreds of economists have said, yeah, we have to do this and we have to do it now. But I think most importantly is that in just a few months ago, the Congressional Budget Office, this nonpartisan, hated by everybody, Democrats and Republicans hate it because it's just never says what a partisan group wants. So nonpartisan, aggressively nonpartisan group, for the first time in 25 years, reviewed Medicare for All and said that, yeah, guys, we can eliminate cost sharing. We can expand the benefits in the way you're saying, provide universal coverage. And yes, we can afford it. So CBO recently said that, yes, of course, this is affordable. So what's in the new bill? The new bill has 4 key improvements over what we've had for the last few years. The first is, this is 2021, not 2019. And so the bill sponsors have realized that it's time to be much more specific and clear about equity in healthcare. And so they've identified a whole list of issues, not just saying equity, but a whole list of issues where there are profound disparities in healthcare in the United States. And so this list that I'm showing you is for the first time embedded in the Medicare for All bill, and not just once, but there's probably half a dozen times throughout the bill where these characteristics are identified as saying, hey, we need a plan for this. Specifically, there's a part where it says we need to identify what's going on in these areas. We need to report publicly on what's going on in these. And like any good business would do, we need to develop corrective action plans and address these disparities with very specific plans. So there's far more detail about that, and that's all new this year. There's also an increase in funding for Indian health services, much more than we've seen ever, I think. Secondly, the bill expands the benefits in some subtle ways. For the first time, it adds into the articulated coverage for licensed marriage and family therapists. That's new. And it specifically calls out, not as a rules piece, but as legislative piece, transportation, when it's really important for older or functionally limited individuals. As you may know, sometimes more importantly than insurance, you can have insurance, but if you, and even with low copays, but if you can't get transportation, you can't get healthcare. And I see this all the time in the clinics where I volunteer, is the transportation is really important. So it calls that out as an expanded benefit. and more protections. So things that the insurance companies love to do that mea culpa I help create in some ways, or certainly improve on or build on, prior authorizations and step therapies, these things would become illegal. No more of that. It would be you and your physician, no longer the insurance intermediary with step therapy and all that stuff. And I think a lot of us have been worried if you do a program like what we're describing, and Biden and Harris, for example, aren't presidents forever or whatever, and we get a president who comes in who's going to be not quite as generous to healthcare as we might want. They could do something egregious to the benefit design, just with a change in the executive branch of the government. Well, the bill specifically says no, you can't do that. The bill, for the first time ever, specifically says no. If you want to reduce the benefit design, if you want to drop off drug coverage, if you want to reduce the benefit design, that takes a literal act of Congress. So far more protected than it's been in the past, and expanded definition and description of what's provided for the displaced workers, employees who might have disruption of that. We can talk a lot more about that during the Q&A if you want to talk about the impact on workers. But just know, bottom line, extensive protections with income protection and various other things to think about. So much more on that topic than we've seen before. And being 2021 and a pandemic, a lot more preparedness for public health disasters. So the previous bills have had a mention of that. This bill now has much more language on it, demanding or requiring, legislating a year-long stockpile of personal protective equipment and all the other things that we saw catching us with our pants down, so to speak. And we're talking under this bill about putting hospitals on what's called a global budget. So they would have an annual budget to use rather than sort of nickel and diming every drop of the IV pole. They'd have an annual budget, and that budget, the bill says, would have automatically surge upwards during a public health emergency, so that hospitals who couldn't do elective surgery because of a pandemic would still be kept whole and would be able to use their staff and resources to do the public health work that we so desperately didn't have access to. So that's sort of the nickel tour of Medicare for all. But then some would say, well, why Medicare for all? Why do that big step? Why not just let people who want Medicare buy a policy for that? Why not just let people buy that? In other words, the public option. Why not just give Medicare a retail price, put it on the market, and add it to the exchanges, the marketplaces. And if somebody really wants Medicare and they're not 65 or whatever, let them pay retail and buy it. Why not do that? That's sort of the free market concept, and it's appealing from a free market perspective of if it's a good public option and it's got value, people will buy it and it'll thrive. And if it's not so good, it'll die on the vine and it'll disappear. And so this idea is really applying the free market to healthcare. That's essentially what the public option is. And let's unpack that a little bit more. So the idea has merits to it. And of course, we'll tell you some challenges, but it has some merits to it. So the merits are, in one sense, what I just said. It's one more choice. And we know we in America, we love our choice. It's one more choice of health insurance. And oh my God, it would have been a better choice for my sister-in-law, but one more choice of health insurance. And it would apply the free market, which is very appealing to some folks. It's potentially a pathway to universal coverage. If it's such a great value, everybody would buy it. So maybe it's universal healthcare. And it wouldn't be as disruptive, of course, to the insurance industry, which is roughly 18% of our economy. So that's more of an incremental process that is less frightening to some people. And it's an easier political lift. There wouldn't be as much opposition to it. So these are all sort of what people who advocate for the public options say are the reasons to go down that road. The challenges are, it's hard to believe that it's a much easier political lift. We see advertisements from the insurance industry that say things like, well, single payer or the public option, that's all communism. That's all socialism. You really want a public option and socialized medicine. So the advertisements from the insurance industry against us are blurring these two things together. It's not clear to me that it would be a much easier political lift, but that's a challenge. it's really not clear to me that that having one more choice is such a great idea. We like choice. I like choice of having the cell phone that I want, right? But I really don't want to have to pick my cell phone network, right? I want a good cell phone network. So people pick their cell phone network to see if, well, is Sprint, does that cover where I live or where I travel to? What about AT&T? Does that, so we pick our network. We want a choice of network because all of our networks are crummy. So we don't want to have to pick our cell phone networks. We want one good national cell phone network for the whole country. But we do want to pick our phone because, I might want a really good camera. Well, that might be important to you. You might want a really good this. You might want bigger buttons or smaller buttons. I don't know. So we want to pick our cell phone, but we don't want to keep worrying about our cell phone networks. Same thing, of course, beating this something around in healthcare. We want to pick our doctor and hospital, but oh my God, we don't want one more choice of another crummy insurance company like my sister-in-law had to deal with. So it's complexity, and the complexity means it's just one more product. It's more complex. That means you don't get the savings of having reduced efficiencies. So we still have to manage dozens or more insurance companies as physicians in practice, and hospitals have to manage that. You can't get the leveraged purchasing power, on prescription drugs if we're all fragmented with just one more choice. So you don't get much of the savings from a public option automatically. And it's easy to imagine without the savings that it becomes a sort of a death spiral into a high risk pool where if you don't get the savings, it becomes expensive, and then only the sick people pick it. And then it becomes even more expensive, and then only the sicker people pick it. So that's called a high risk pool. And every time we've tried a high risk pool in the United States, it has devolved in exactly that way and become unsustainably expensive. So you could imagine that happening with a public option if that's put out there. Public option wouldn't automatically be any help for the tens of millions who have crummy insurance today, right? It's designed, or the main intent of a public option is for the uninsured, giving them a good choice. What does that do for somebody who's got a $6,000 deductible or a $10,000 deductible through their insurance company? Well, not enough. It's not anything necessarily. So not much help for them, and millions would probably remain uninsured. So this is where the discussion about the public option, frankly, from my organization's point of view, Physicians for a National Health Program, this is where it stops. This is where I used to stop in it. But, our president has said that if he's going to pursue expanding healthcare, this is a much more likely pathway for him in the next 2 to 4 years than is single payer. So that doesn't mean he wouldn't do it. Lincoln didn't run as an abolitionist. Roosevelt didn't run as a New Dealer. Johnson's pre-presidential history didn't suggest he was going to be, a big advocate for civil rights. So the fact that Biden is not clearly in favor of single-payer Medicare for all does not mean that it's dead in the water right now. And indeed, I showed you a lot of reasons to think it's not. But he is more favorable on his own of the public option. So I tried to look more closely at this. And what can you do to sort of mitigate the risks that I've identified? Well, there's actually a lot you can do. And so the first thing is this concept of it being blurred as single payer. And, that as soon as you enact the bill, right, most of that issue disappears. So that's a self-limited problem, so to speak. The complexity, that's a design flaw. You can't get around that. That's a design flaw. You could get around some of the problem of not getting enough savings if you make it truly public. And we're going to talk about that. You can't get all of the savings, but you can get some of the savings if it were really a public program. We'll talk about that in a moment. What about the high risk pool? Well, that's a big deal. And that's where what I would propose to you, size matters. If you can make it large enough, quickly enough, this high risk pool concept is nowhere near as profound. And I'll show you how we can do that. And the uninsured, underinsured, well, offer it to everybody. Make it to anybody who thinks their insurance isn't adequate and that wants it, make it available to them. And we'll talk about that for a moment too. And how do you get the uninsured into it? Well, there's one important principle from behavioral economics that I want to tell you about. So let's talk for my last little bit of time here about what a good public option would be. 3 key characteristics. First is that it would be public. It would be strongly tied to Medicare and not to Medicare Advantage. Medicare Advantage is commercial. It's generally a for-profit Humana Blue Cross. It's not really Medicare. We can talk more about that if you want, but tie it to Medicare, not to Medicare Advantage. That means tie it to a national program, not state-based like Medicaid, not Medicaid for everybody. Then you don't have coverage in Texas when you travel out of Missouri. So national, with all the national merits, using Medicare's existing national network, and encourage physicians and hospitals to take it. If they want to take Medicare, they got to take the public option. So that would mean that it would have the complete national network. Don't take Medicare as it is today, make the public option better, add in things like dentistry and pharmacy that we know everybody needs. Also, the public option, the best public option, would eliminate copays and deductibles, and of course, make it affordable for people who can't even afford the premium that it would have. And starting big, this is really important. So starting big means automatically enroll everybody in the country who is uninsured. Automatically enroll everybody in the country who's uninsured. Are you going to say, wait a minute, that's a mandate. That's, that's going to be, So enroll everybody, but allow anybody who's enrolled to opt out. So auto enroll, but if you say you don't want this government healthcare, if you don't want it, fine. It's really easy. You can get out. Just opt out. You don't have to have it. Auto enroll everybody, but let anybody who wants opt out. That's incredibly important. The behavioral economists taught us with retirement funds that employers tried matching your IRA savings up to 6%. And even with a 6% match, IRAs never got more than about a 15% adoption across the country. And then employers switched to auto enrolling and letting people opt out of the IRA investments, because of course it's your own money. You can't be compelled. So auto enrolling and opt out, and enrollment in IRAs, retirement plans, went from 15% to 85% very quickly. So auto enrolling all of the uninsured, but letting them opt out, is the key to making it big right off the start. And that's the key to dealing with the problem of only sick people would be in it in adverse selection, and let anybody else in it who wants to be in it. So if you have insurance from your employer, but you'd rather have this, you should be able to switch to that. If an employer doesn't want to keep offering Cigna or whatever it is that they're offering, and says, I'm sick of shopping for insurance benefits, let an employer move their entire book of business over to the Medicare program. If a state wants to stop having to deal with, organizing and structuring their Medicaid plan, let a state move everybody from Medicaid over to this improved form of Medicare for all. So if you do these things, it would be big, it would have momentum, and it would keep growing. So these are individual characteristics to pay attention to if indeed the public option starts moving forward again, which President Biden has said he will do. So pay attention to this, each of these important characteristics. Last thing I just want to say is don't blow off rural Missouri. Don't blow off rural Missouri. These red-blue states, we think, we think, well, it was rural Missouri, that we had to overcome. No, if you look at the votes, a lot of people in rural Missouri voted for Medicaid expansion, just to lead into Dennis's topic. Had they not voted for it, had those yes votes in rural Missouri switched to no votes, those 81,000 votes, it wouldn't have passed. It wouldn't have passed. So Adair County, 62% voted no, but that was 2,000 people who voted yes. If they had all voted no, it would have failed. We would have lost Medicaid expansion had that failed. So my very last thing, it's my third last thing, is to tell you that you can join Physicians for a National Health Program. Go to showmemedicareforall.org. Follow us on Facebook, Physicians for a National Health Program, PNHPMO. If you can't remember that, you can find it at the showmemedicareforall.org site. And that's it. And I'll take you over to Dennis.
Sure. Thank you, Ed. And now we're going to go let Dennis McDonald talk about what's going on in the Medicaid, and then we'll open up the questions. I'm sure that you've all got many questions.
All right. Hello, everybody. Again, my name is Dennis McDonald. This is not the first time I've had to follow Dr. Weisbart, so don't feel sorry for him. He always gives a good presentation. And I'm really thankful for that last slide, because that's one of the things that, especially when we talk about our state and right now, before we get into that, I want everyone to think about something else. I want them to think about the night that we passed Medicaid expansion in Missouri, and how awesome and good that felt to think about a 10-year fight that a lot of organizations, a lot of individuals, and a lot of people across the state had been fighting for 10 years. And actually, I got involved in my current occupation as the organizer for Missouri Healthcare for All because I was asked to share my story because I was someone who fell in that Medicaid gap. So it really, it's not only something that affected my life personally, but people I know, and as you know, hundreds of thousands of folks across the state. And again, it's a statewide issue. So thank you, Dr. Weisbart, for reminding us of that point, because a lot of people tend to forget, especially when we get caught up in like maybe not feeling so great this week about what's going on with Medicaid expansion over the past couple of weeks, right? So I'm sure a lot of folks are aware the third final fight. I'm gonna use that from now on, because we had our final fight at the ballot box, and then now we have our final fight in the legislature, where they refuse to include the funding into Missouri's budget for Medicaid expansion. Now, again, this is going to sound familiar because Dr. Weisbart just talked about some of these things. We all know that the expansion of Medicaid in Missouri was going to be a really good deal for our state. It was going to bring a lot of federal dollars home that were currently going to other states and weren't being used to cover people. So basically, Missouri is one of those states that was in the position of paying a lot more money as part of our state budget to cover fewer people, right? So sometimes people would say things like, oh, Medicaid's this huge chunk of our budget. Well, sure, because we're only getting about 60% of the money that we could be getting coming back to our state. So, it got to it's to the ridiculous point to where by not accepting these federal dollars, we were covering less people and it was costing us more money. We went to the people, we got the signatures, we got it put on the ballot as a constitutional amendment. It passed. You can all, I'm sure, talk about your feelings about whether or not the legislature did their constitutional duty, but that's an issue. So that's why they didn't add the funding in their budget. We hoped that the Senate, and we fought really hard in the Senate to try and get the Missouri Senate to kind of bring sense back and fund this. Now they did it. Now ultimately, the governor put Medicaid expansion money in his budget proposal. So it's not, again, this wasn't something like Governor Parson knew that this was coming. It's a constitutional amendment to our state constitution. He made provisions for it. The legislature and the Senate decided not to participate in that. So as of today, it is not funded. So what does that mean going forward? Well, in Missouri, our constitution now says folks that were not eligible for Medicare enrollment previously are going to be eligible on July 1st. So who are those people? Right? Those are the people that we've been fighting for, the working adults, the single adults, the people without children. Again, it's a big group, a diverse group of folks that were not able to qualify for the subsidy on the exchange. And they made too much money to qualify in Missouri, because Missouri, of course, had some of the lowest qualifications for adults to qualify for Medicaid in the country. Basically, for a single adult, it was around $3,000 a year. If you made that much, you weren't going to qualify, right? Now, your children may qualify, but the parents didn't. So we had, again, to me, it's a ridiculous situation. We had households where children were able to go to the doctor, but their parents were not, right? So again, we all know what happens if you get sick. If you get sick, you can't work. All these kind of things start to compound. So again, it's a ridiculous situation. Finally, we took the steps to solve that. This week, we're kind of at the end of it, so to speak. The legislature is going to not meet on Friday, or they're going to meet until Friday, and we're going to plan one kind of final push to get this. Our suspicion is this is going to go to a court, right? So someone's going to enroll in July. It's going to get challenged in court, so we're going to go to the Missouri Supreme Court with this. So the kind of, and again, I'm not the person to talk about to get too deep into this, but people who weren't eligible are going to be able to sign up in July. They're going to sign up, right? My wife is going to go sign up for Medicare because she qualifies in July. Medicaid is not funded, will not be funded in Missouri because a lot of more people are going to sign up. So that's going to be the issue that the court, the legislature, and everybody's going to be dealing with over the next couple of months. Now, again, I recognize some of the names of folks in this room, so I know you were on phone banks when we were doing this stuff. And I know a lot of people have been fighting this fight for a long time. So you may be asking yourself, well, what can we do now? Well, what we're doing as an organization, and again, it's not just us, right? I guess I should have talked a little bit at the beginning about Missouri Healthcare for All and who we are. We're a statewide organization that does grassroots organizing and organizing in the Capitol. Obviously, for the last 10 years, we've been focused on closing the Medicaid gap. We've done work on things like surprise medical billing. We've come to the point to where, again, we agree with Dr. Weisbart's take for the most part. These incremental changes, while important, and we're going to continue to fight for those and try and keep people from being kicked off the Medicaid rolls or denied service for whatever reason. We believe that Medicare for All is the best situation going forward, right? And for all, again, I'm not going to go through all the reasons. We believe in all the reasons Dr. Weisbart said. It's equitable, it's cheaper, people can control their healthcare, all those same issues. So we call those our pillars. Again, if people have particular questions about what that looks like as far as an organization in Missouri, I'll be happy to talk about that more during the Q&A. But what we're doing Friday is working with a lot of other statewide organizations, Jobs with Justice, and other groups that, again, we've all been in this fight for 10 years, and we're going to have rallies across the state to secure Medicaid expansion. We want to let the governor know that the people of this state, again, as Dr. Weisbart showed in that slide, not just the people in St. Louis and Kansas City or Springfield and Boone County, the people all across this state need Medicaid expansion to be implemented, and we need to be implemented July 1st, like we asked for and we voted for, right? So if I can screen share real quick, I will show you. Yes. So if everyone can see that, this is our website. I'll put a link in the chat real quick if people want to sign up. And again, if you're following other groups from whether it's Jobs with Justice or other groups, we're all kind of doing the same thing. So there's not one in West County. Again, I'm from Jefferson County. We'll have one. It's in Arnold. It's not that far of a drive. If you want to, we're going to be on the side of a popular intersection there. We have one in Joplin, Kansas City, West Plains, which if you're familiar with our state, you'll know that there's some healthcare advocates that are absolute heroes down in Howell County in Missouri that are having their own event. And then there's going to be a large one in St. Louis, obviously, probably one of the bigger ones on Shoto. And then we'll have another one in Springfield and also Columbia. So if you, the link didn't work, sorry. I'll see if I can get it to repaste. But if you can just go to Missouri Healthcare for All or any of those, we're on Facebook or any of the social medias and get logged up to go to one of those. We're going to live stream them on Facebook. So if you can't make it, maybe you can boost the signal by live streaming on Facebook and showing your friends that, and showing the governor that we want this to take place on July 1st as we voted for. So, and with that, I will stop sharing my screen for now and try and share this in the chat. And again, if anybody has any questions about the pillars moving forward or anything like that, I'll be happy to talk to them. So, and thanks again for having me.
Okay, this is Maureen Jordan again. I'll start asking questions. I think the best, we've got a lot of questions, is to pretty much go in the order that they've been received. And Brian, if you've seen I missed one, can you be my person that keeps me in line and jump in? So, does Medicare for All eliminate employer-based insurance, and what would the transition look like?
So yeah, Medicare for All would replace employer-based insurance. Instead of worrying that when you change jobs, you have to, maybe have a restart of waiting till you qualify for your new employer's insurance. You would have the freedom to keep your health insurance unrelated to your employment. So uncoupling it from your employment is a core feature of a core goal of what we're trying to accomplish. But what does that mean? How do you go from the previous bill two or three iterations ago, it went from 0 to 100 overnight. It said no Medicare for all, no Medicare for all. And then 2 years later, abruptly, everybody switches. Nobody's talking about that anymore. That's not the plan. The plan now, instead, both the Senate and the House bill have sort of an age-based transition where, first bring it down to age 55, then age 45 and 35, and bring kids up on the bottom end. And so sort of take 2 to 4 years, depending on which bill it is, where people gradually age into the program, gradually add in a few other groups. So the transition is something we would get through. Hopefully that's what you were asking about.
And that brings a question to my mind. Amy, thank you for asking that. Would there not be a benefit to companies to wash their hands out of providing insurance? I mean, that's an enormous spend for them.
So if you just abruptly said employers are out of the game and all of that money is going to be paid out of taxes, then yeah, that would be a windfall for employers. And then are you supposed to just like hope that that money gets put back into wages and salaries? No. Nobody's naive enough to think that employers would that would happen. So both of the bills talk about the initial phase of having employers continue to pay what they pay today for health insurance, actually a small amount less than what they pay today for health insurance, but just not pay it to the commercial insurance industries, instead to pay that amount slightly reduced into the federal government as part of the other ways that they pay into the federal government. So take those same resources, don't give them a windfall, take those same resources and then pull them over. So all the proposals say to start that way. And frankly, nobody's crazy enough to say, let's make a 25-year plan for how this finance is going to work out. Let's, everybody I think agrees that the long-term plan or the even short-term plan is to migrate the finances away from employers and more into just the regular equitable tax model that we pay for other common goods. But there's no granularity around the timetable for that. But there is pretty strong agreement, not universal, but strong agreement that that's how that would work. So no windfall. Yeah, no.
Thank you. That's an interesting answer. This is so new that your mind just thinks, gosh, how is this all going to work? So would the premium we pay now go to the employer or the federal government? And could it be a tax write-off? You may have kind of answered that. If you could just clarify. Yeah.
So employer premiums, we sort of just talked to. Personal individual premiums, well, there essentially wouldn't be a reason to be paying a personal individual premium. There wouldn't be an insurance company on the market that duplicates the range of benefits that Medicare for All provides. So as long as Medicare for All were designed in a robust way as we described, there wouldn't be a market for what would the insurance company sell? They could sell things that weren't covered, but our intent is to have everything that's, and the proposed legislation has everything that's medically appropriate would be in the insurance industry, would be in the Medicare for All program. So there wouldn't be this niche. Does that mean that you would just sort of stop paying premiums and that's the end? No, of course not. There would still need to be a funding piece, but instead of it being a flat premium that everybody in the country has to, sort of pay through their job today or whatever, instead of that, it would be embedded into the progressive income tax, so that the lowest income folks would have, zero or very, very minimal amount, and the top end, the most wealthy people would pay a fair share, which would be, more. So in general, it's hard to put a number on it and say, what would your taxes be changed to? I can't give you a number that says if you're paying this today, you would pay that tomorrow, because there's so many moving parts that anybody who gives you a number like that would be making assumptions that may or may not bear any reality. So I tend not to do what I've seen some people do, to say, well, you'll pay this. Can't say that. What we can say is that you'll pay less. We can say with great confidence, because you'd eliminate so much of the overhead. You'd leverage purchasing power on drugs and all these things. You would streamline the flow of hospitals just automatically, not requiring fancy maneuvers. The simplifying the payment structure creates tremendous savings. So the whole system would cost less. Dozens of models have shown this. So you would pay less. Almost everybody would pay less. I can't say you, Maureen, I don't know that, but almost everybody would pay dramatically less, and the people that wouldn't pay less, probably are doing pretty well from the way the stock market and stuff has been changing. So yeah, you'd pay less. Would it be a tax write-off? Well, no, it wouldn't be a tax write-off. It would be a tax, right? You couldn't write that off. I mean, that would be part of what you're paying for in your taxes.
Okay. Amy is also asking, I work for a medical diagnostic company. What would Medicare for All do to our industry? And could hospitals still choose their own products and services, or would this be dictated by Medicare and CMS?
So there would be no need for CMS or Medicare to dictate which products and services hospitals would purchase. And indeed, that would sort of undermine one of the goals, which is to stimulate real innovation. So the hospitals would be put on, in the House bill, and the one that my group proposes, hospitals would put on an annual global budget where they would know every year, they would renegotiate it every year, but individual hospitals, not chains, not 300 hospital chain, they could still exist, but each one of their hospitals would negotiate individually with CMS for their annual budget based on benchmarks and things that make a lot of sense that are spelled out in the bill. So hospitals would negotiate that, and then they would have a budget to live within. And then if they chose to do something that was today, if a hospital chooses to do something that's a lot more expensive, oftentimes that means that they can get reimbursed a lot more money for it. And so there's sort of this cycle of chase the most lucrative thing, and if it costs more to do it, well, you can kind of recoup that by showing that as part of your cost model. You can chase. So that's not always the case, but hospitals today are chasing after the most lucrative thing they can under this model, right? If somebody innovate, they'd have a budget. And so if somebody comes up with an innovation of a way to improve medical devices in a way that actually makes clinical and economic sense, well, then they would capture the market because they're making sense. And they would be driven, and the competition would be to do it efficiently and effectively rather than today's model of do it in the most profitable and lucrative way. So medical device manufacturers would have, I would think, a heyday of competition for actually improving the quality and the innovation of efficient products. Today, an orthopedist oftentimes comes up with their own device that they want to do. In a hospital, they have to stock 12 different redundant devices, one for each one that each one of them want. And when you're only going to buy one instead of 12, when you're buying 12 different ones, you can't get down to a good price. So this whole thing the model we're proposing builds way more efficiency at this, but never does it say that CMS would mandate you have to cover this device, you have to cover that, hospitals have to use that thing. There's no mention of that in any bill.
In fact, in the job that I retired from, major hospital systems were already limiting the number. For example, they went after orthopedics first, the number of devices that they are going to stock. They just, because it costs so much money. So that's probably going to be nothing new, to most hospitals at this point in time, or hospital systems. From Mike Albrecht, I think it's Bleach, to everyone. Sorry if I'm not pronouncing that right. He's making a comment, and I would like for either of you to respond to it. 10 years ago, I served with Donna Shalala, and the Institute of Medicine released our Future of Nursing report. Today, a report was released by the National Academy of Medicine on nursing's contribution to health equity, led by Mary Wakefield. Senator Bill White and Bob Onder continue to railroad the use of nurse practitioners as primary care providers. We are one of the most repressed states in the U.S. in their use and have restrictions on mileage, etc. It's a travesty that we live in a state that has a maldistribution of primary care physicians, and NPs could aid the care options as was allowed by Governor Parsons for COVID. Payment is one issue in this state. Medicaid is huge. At some point, it would be helpful to have a broader discussion on what is going on here. Thank you for those of you who might share this concern. Our two speakers tonight are exceptional and make my heart sing. So would either one of you or both like to comment on that?
I have one comment I'd like to make, and then hand it back to Dennis. And the comment I'd like to make is that this is one of the things I most love about single-payer Medicare for all. This is one of the things I most love about it, which is, and I'm going to broaden the question, if you can come up with anything that makes good economic and clinical sense, for the first time ever, the partner on the other side of the table, negotiating the contracts on the other side of the table, really does want that with the power and authority of the United States government. So nurse practitioners, physician's assistants, or a variety of other people who say, hey, I can do this work, I can do it really well, and I can do it actually, because of these various reasons, I'm more efficient at it. You can make that case, then you have a business case to really ramp that up. And it would be federal. It wouldn't be open to, you know, the Bob Andres of the world to make, you know, their little flavor of the month, you know, sort of perspective on it. It would be a federal policy, you know, much like how Medicare, I don't know if you know this, but the reason hospitals across the United States are racially integrated, certainly didn't end racism, but racially integrated, is because in 1965, Medicare federally said, if you don't integrate as a hospital, if you keep blacks and whites in separate wings as a hospital, you're not going to get any of the juice. No Medicare money is going to go to your hospital. All the people over age 65 in your community who want to use your hospital, not a one of them will be able to pay your hospital, and they'll go somewhere else if you don't integrate. And it was still a struggle, but when the federal government said this is an important step forward, you know, we almost take for granted that we no longer have, you know, people giving birth in the African American wing of the hospital. You know, it's changed. And the same thing would happen with nurse practitioners and physician's assistants, right? It would be a federal policy about what's covered, who's empowered. And I think this is a huge step forward. This will be a huge step forward for non-physician providers of care, the ones where there's really a lot of sense, which I think this is. Dennis, do you have any thoughts about Medicaid's implications?
Well, I mean, I would say this it checks all the boxes as far as reducing barriers and cost. And, you know, even if it was something that we could do before we have, like you're talking about with the federal system. So yeah, absolutely. It's, you know, again, we support anything that's going to lower the cost and give more folks access. And like you said, if, you know, right now there's acute barriers to care because of the what's the right word I'm looking for? The lack of, you know, exactly what Michael's talking about in his comment, the ability for nurse practitioners to be a more important part of our healthcare delivery system. So absolutely.
Dennis, I noticed that you said that you forgot to mention something. Did you want to mention it now?
Yes, I would have never forgiven myself, and I meant to put this on the end of my talk. Another thing that we can do, and a lot of people like, and again, I fully support this, calling our senators and our legislators, our local senators, our local legislators, and the governor. Just in case the governor's office is a little tricky right now, they don't have a voicemail set up, so but keep trying because you never know. And that is the ballot initiative, right? The reason we were able to expand Medicare, sorry, I keep saying after following Dr. Weisbart, I keep saying Medicare. The reason we were able to expand Medicaid in Missouri was through the use of the ballot initiative. There's still time for them to make that much more difficult moving forward. So, you know, today, tomorrow, this week, if you get a chance to talk to your legislators or your senators and let them know that you want to keep it the way it is, because what they're trying to do is make it more difficult for these citizens petitions to even get on the ballot and or attach a cost to it. So that'll stop a lot of these kind of grassroots and ground up petitions that we've all seen, you know, be tremendously successful over the past 20 years. So, and that's another thing that we're looking at doing now. So.
Thank you for adding that. That is important. Michael had one more comment. If we expand insurance, there has to be providers to fulfill the needs in a system that was never designated to care for all people. Do one of you have a comment about that?
I do. We're not as under-resourced in providers as you might think. Just on the physician side, we have slightly below the average number of physicians per person in the United States as they do in most other countries. We are not in this dire shortage of physicians. We have slightly below average. The problem is twofold. We, number one, have twice as many subspecialists as we do primary care physicians, and that's driven by the reimbursement model, that's driven by student loans, all things that we can address under Medicare for All. And the other reason it seems that we're under-resourced in physicians is because 25 to 50% of the time for a doctor is spent dealing with nonsense. It's spent dealing with prior authorizations and non-approvals and appeals and all this crazy, you know, non-clinical administrative nonsense. You know, some physician practices spend more than half of their time with the physicians doing non-clinical work. In comparison, in Canada, the typical family physician in Canada spends 4 hours a week doing non-clinical work, less than 1 hour a day. In the United States, often more than half of our day, or certainly nearly half of our day. So if you put in a system where none of those distractions exist, or much, much fewer of those distractions exist, well, then guess what? Most of us are in medicine because we actually like seeing patients. Most doctors are actually happiest. We may, complain about it, but we're actually the happiest. The doctors who are the happiest in the United States are the ones who spend the most of part of their day seeing patients. And the doctors in the United States who are the least happy are the ones who spend the fewest percentage of their day, the smallest percentage of their day seeing patients. There's evidence about this. We love it, and we're happier when we can do it. So if you remove a lot of this nonsense that we're distracted from, which is material, it's a big part of our day. If you greatly reduce that, we would suddenly not have these problems. And maybe another part of the answer, do we have enough doctors and nurse practitioners? Another part of the answer is when you look at 1965 Medicare implementation and look at when the ACA was passed in states that had Medicaid expansion included, and look in other countries where there are significant leaps in the percentage of their population covered, physicians see the same number of patients for the 2 years before and the 2 years after. Physicians see the same number of patients. Even when Medicare was passed and you added on tens of millions of the sickest Americans, the seniors, when Medicare was passed, and in the ACA, when states expand, the 2 years before and the 2 years after, we saw the same number of patients per year. What we did was we told people who were healthy and didn't need to come in that often, we stopped telling them to come in. Somebody who didn't really need that hip replacement, we stopped telling them as much that they needed to do that. We drive a lot of our own business. The number of hip replacements in a community is related not to the number of seniors, it's related to the number of orthopedic surgeons in the community. So we drive our own business. And what happened in all of these times I was describing, 1965 with Medicare, the Affordable Care Act, even in states that expanded Medicaid, and in other countries with large growths in the percentage of covered population, in every one of these, what happened is the very wealthy and not so sick people came in marginally less often, making room for the others. And in the ACA expansion, there was a survey done 2 years before and 2 years after asking people, well, we're worried if you're going to come in less, are you going to perceive it? So they surveyed people and nobody perceived a change in their ability to go see a doctor the 2 years after versus the 2 years before. So we have the resource, we have the technology, and then combine that with making a case for adding in nurse practitioners and physician's assistants, which we need to do that. I mean, it just makes sense. There's so much that they can do that they should be doing that, frankly, I'm not saying that they're just able to decompress. They're better at, in my experience, a good physician's assistant and a good nurse practitioner, staying within the bounds of what they can do, is frankly better at that stuff because that's their core meat and potatoes. And physicians oftentimes don't take some of those issues seriously enough and don't do it as well. So I would argue that it's an improvement, not just a parity. It's an improvement to have that. And this is the system that builds that has a financial business case for making that happen. Long answer to the question.
That's compelling. That's compelling. There was a question here about people. Okay, Betsy. Okay, what does Medicaid or Medicaid expansion offer elderly citizens who have exhausted their assets for long-term care?
Dennis, I think you're on for that.
Oh.
I don't know that I have the answer to that.
Dennis, can you hear me?
Okay. Oh, sorry.
Oh, sorry.
Yes. Well, I mean, are we asking about like people that have already currently exhausted their assets, or like not having that be an issue in the future?
It sounds like for people, elderly citizens who have exhausted their assets for long-term care, where do they go? Is there a provision for that in Medicaid expansion?
No, Medicaid expansion is not, and again, it's not changing Medicaid. So it's the expansion doesn't change anything about the current Medicaid system or the Medicaid programs as they exist today. What it would do is, or what it does, I'm going to quit using the past tense. What we have done is we've expanded the eligible population, much like what was done in other states immediately when the ACA was passed, and as other states have done gradually. So it's those folks that earn too much money to get Medicaid, again, over that $3,000 limit if you're a single person, and then don't qualify for subsidies on the exchange. So for, disabled folks, now, and again, there's a lot of, it's a complex system, as Dr. Weisbart pointed out. There's potentially groups of folks that are disabled or are getting income from other sources where it may have an impact, but that, again, we're not, I wouldn't be confident enough to say 100% that that's going to change that. But again, the good news, I'm going to make another plug for what Dr. Weisbart's talking about, is universal single payer eliminates all of that, all of those problems and those heartbreaking stories that we all know. My grandma went through it, that we all know people have gone through it. So again, that's another plug for the another benefit of that system for sure.
This is taking a look at the whole Medicare for all in a different aspect. What will become of all the people employed in the private insurance industry and all of those working on insurance claims in medical offices under Medicare for all? I mean, there's going to be a lot of people that won't be needed for jobs anymore.
Yeah, that's a hugely important piece. Anyone who ever loses their job, every time anybody loses their job, it's not just them, it's their whole family, it's their whole community. They're not shopping in the same way. I mean, the repercussions of any job transition are large. And so this particular question has had a lot of attention within the bill's drafting and such. And in fact, labor had a lot to do with the bill's drafting. They were well represented on it. So there's some things to think about. The first is how many people is this? And I think the easiest round number is around 1 million people whose jobs would be directly impacted by this. There's a range of estimates, but I think 1 million's more or less the ballpark that it's at. So what happens to them? The first thing is that, the most straightforward part of the answer is that both bills talk about income guarantee for anybody whose job is displaced. So for the first 2 to 4 or 5 years after the bill is enacted, income up to a certain level, I think the number was 100,000 in one iteration, income up to a certain level is continued if your job is displaced by this. So income protection. And then at the end of the income protection period, you then could first enroll for unemployment. So that's nice. There's no rug being pulled out from under your feet with, job retraining and job training and job placement and all that sort of stuff. Most people that I know aren't as focused on income protection as they are on meaningful work. It's meaningful work that most of us really, really want. So income protection is good. Know that it's there, it's baked into the cake, but we need more than that. And frankly, the employment situation, I think, is fantastic under Medicare for all. So sort of at a few different levels. First, within healthcare, well, there's lots more healthcare we got to do. So there's stuff that's directly in healthcare that there's no business case to do today that you don't have to be a doctor, nurse, or physician's assistant, nurse practitioner. So, doulas when people are in labor, somebody who's one of the most common reasons to be predictors of hospitalization is social isolation. So a senior who's shut in and has no contacts with people, that's the person who's the most, even if they're not that sick, the sickest ones with social isolation don't have as much of a problem. So vice versa. But social isolation is one of the biggest predictors of hospitalization. So what you can do, and some countries do this, is send somebody with relatively limited clinical training, a few weeks, maybe a month or two, into everybody's house. If they're on the list as being at risk of social isolation, have somebody come by every couple of weeks and go, hey, how you doing? Have a small talk conversation and notice, goodness, you've got dishes piled up. You didn't have dishes piled up last time I was here. Are you getting around like you were? What's going on? That kind of thing prevents hospitalizations, pays for itself. There's nobody today with a business case to do that kind of work. That's just one example. But under Medicare for all, that kind of work and dozens of other things that we don't do clinically today that don't require being a nurse practitioner or a nurse or any of those things, suddenly there's clinical work that needs to happen. Then there's clinical work that needs to happen that is completely non-clinical, but somebody has to build the clinic, right? There's construction work. If suddenly North County is a greenfield where physicians want to go to practice because there's no competition and they can overnight have a busy practice. They don't have to compete with all the docs in Clayton. They can overnight go there and have a resoundingly busy practice and pay off their student loans. Well, somebody has to build that building. Somebody has to wire it. Somebody has to put the roof on it. Somebody has to update it if it's an old building. There's all this construction work that has to happen. So there's a boom in that kind of work. And then employers within the United States who are stymied about growing their employee base within the United States because they know that it means this outrageous cost of healthcare, right? Sometimes more than the wages that they're paying, especially how low wages are these days. But employers could suddenly grow their workforce without the same punishments they take today for paying for healthcare. And employers outside of the United States who want to relocate here would become more able to. So I know of a factory in Canada where they get their raw ingredients from the United States. They have them shipped up to Canada for the employees to construct things. I don't know what they build, but they construct things. And then they ship them back to the United States where the biggest market is. And the CEO, who's a member of the Canadian Conservative Party, wants to relocate to the United States, but can't because the higher cost of healthcare here would put him out of business. So there's work within healthcare, there's work adjacent to healthcare, there's work unrelated to healthcare, and there's work from outside of the country. All of these things in countries that do these kinds of changes would be stimulative to the labor market, not punishing to it. So there's lots of there's mitigation, but to me, actually, one of the more interesting ways to look at the labor question is well, actually, two more things. Sorry, my next to final thing. Two more things. Most of the work in the insurance industry of healthcare has nothing to do with healthcare, right? It's claims processing, it's call centers, it's data management, and that work is identical for property casualty, life insurance. So Prudential, for example, when they 20 some years ago left healthcare, they didn't have massive layoffs because they beefed up their life insurance and property and casualty. So some of those jobs don't even disappear. They don't even disappear. They just migrate to other related fields. But to me, the final part of my answer to this is the idea that how many is a million? Well, it's a million. It's a big number. How many people change jobs today? Well, today, for the last 2 decades, I don't know COVID numbers, but for the last 2 decades, 20 to 30 million people quit their job every year. We're talking about 1 million. But for the last 2 decades, 20 to 30 million Americans have quit their job every year. And another 20 or 30 million Americans have gotten fired every year. And another 5 or 10 million leave their job for, they die or they retire or something. So every year for the past 20 years, as far back as my data goes, we've had 60 million, 60 million, 60 million, 60 million changing jobs, 60 million, 60 million. Now we're saying 61 million, 60, 60, 60, 60. And that 1 million bump is real, it's important, but it's got all these mitigating concerns. So I think we can get through this. We have to get through it. It's killing our economics.
Like you're just a wealth of information. It's just astonishing. From download to everyone. Okay. Pardon me?
It's amazing what you can come up with when you make things up here.
Yeah.
Well, actually, I have sources for everything I've said.
I know you do. From download. Real quick, and I think I know the answer to this, but Dennis, since the Missouri legislature hasn't funded Medicaid expansion, does that mean the only alternative now is the court?
I answer this with the only qualification that I am out of the predicting what's going to happen in our state business, but that's definitely where it looks like it's heading. And again, if you follow the debate on the Senate floor, even a lot of Republican senators mentioned this fact throughout that debate that this is, if we don't do this, this is going to the courts, and they kind of wrestled with if they want that to happen or not. There are other alternatives. One of them I kind of briefly mentioned, and that is nothing happens. July 1st, people who are now eligible to sign up for Medicaid begin to sign up. Well, what happens then? Well, then at some point in the next year, the Medicaid system in Missouri is going to need some money pumped into it. So that's going to mean a supplemental budget and/or the legislature coming back and doing some additional work as far as providing funding for that. So that's one alternative. There are other alternatives, but again, I'm not advocating that people place bets, but it looks like the court is where we're going. And there's different ways that could happen, right? If they refuse to allow people who are constitutionally eligible to sign up So there's a lot of things that could happen. A lot that we don't want to see, right? So
Okay.
it's the most likely outcome.
From Don Logue to everyone, other countries have forms of universal health care that are not single payer systems yet achieve the more desirable outcomes that you've discussed. Can't we have local owned nonprofit MCOs, I'm not sure what that is, that manage better both risk and outcomes?
So MCOs means managed care organizations, like, HMOs basically and PPOs.
Yeah,
so,
yeah.
So you're right, Don. I presented one solution. I think that's probably the most viable solution in the United States because it's, so there is another, perfectly acceptable to me solution, which is what you're describing. Rather than having one, and I'll describe it, rather than having Medicare, you could instead do what, Germany and a few other countries do and have a bunch of smaller insurance companies that are all strictly regulated, intensely regulated and all nonprofit and are paid a combination of ways, both either through federal taxes or through employers or through individuals. So there are complex payment schemes that then have this constellation of local smaller insurance companies. They typically call them wellness funds or sickness funds, and then those would work as their own insurance company. They would be required to have the exact same benefit design as each other, the exact same network of physicians, the exact same price structure. They would compete on adding maybe other things that aren't covered today, like maybe you can get a new shirt, or something. I don't know, but other things they compete on service. How well do they answer their phone? They would compete on other things, but other countries do it that way. I think of that pathway as the ACO on steroids. So the ACO, I'm not ACO, I'm sorry, the ACA, the American Affordable Care Act on steroids. So the Affordable Care Act did increase the regulations and rules for the insurance companies in the United States. It limited how much they can spend on administration. It redefined the benefit requirements. It kind of went down this road a bit. You could go further down that road in the United States. You could require what Don has suggested, make all the insurance companies nonprofit. You could require them to have, all these things that I just sort of rattled off and more. You could. What I would argue back is that those models evolved organically in those countries, and they happened smoothly in some ways. If you try to do that here, the insurance industry would fight that tooth and nail as they would fight what I proposed. So if you look broadly around the world, the countries that have actually socialized medicine, which we're not proposing, which means that the government not only manages the economics, but the government employs the doctors and owns the hospitals. That's socialized medicine. That's the Veterans Administration here in the United States. That is socialized medicine in the United States. That's how Great Britain does it with the National Health Service, where the Great Britain employs the doctors directly and owns the hospitals. So the countries that do that spend about half, or actually 1/3 of what we spend. Those are the least expensive models. The model I described, which is not a National Health Service, just National Health Insurance, that has about half the cost of what we have today, and that's Canada and a few other countries. And what Don is describing is actually, some wouldn't even think of it as single payer, and it's not national. It's national health insurance, but it's private, it's fragmented and delivered. That of the three choices of a national health service, which is the least expensive, national health insurance, which is what we're proposing, and this kind of complex ACA on steroids model, that's the most expensive of those three choices. So those models tend to spend 1/3 less than we spend. Medicare for All tends to spend 1/2 less, and National Health Service, like England, spends about 2/3 less. So if the country settled on what Don's bringing up about the multiple managed care organizations that are tightly regulated, if that was done in a way that gave us universal coverage and the trade-off just was that we spent more, I'd be fine with that. I just think it's silly to open with that since it's more expensive and more complicated. So I think open with what we know to be the best solution. If we have to compromise on going to that, as long as it meets my criteria of universal and quality and those things, yeah, sure. I would say don't push for that because that's more expensive. I mean, around the world, that's more expensive.
From Kristen Edmonds, when I think about what people would purchase if a health insurance premium were not their largest monthly expense, I wonder if a lot of other industries like automobile manufacturing, home improvement, and travel might get a boost.
Absolutely.
Oh, I'm,
Absolutely. I mean, that's kind of
yeah.
the point is if we're spending, a fortune, I think a family of four now spends, if you look at what they spend and what their employer spends on their healthcare, a family of four today, it's costing more than $20,000 a year for their healthcare, more than $20,000 a year. And we know that a third of that $20,000 is going just to prop up the insurance industry. A third of that $20,000 that a family of four spends does nothing but support the insurance industry, all the ways I was describing, their internal overhead, the hospital overhead, the physician practice overhead, a third of that. So that's, let's say, $6,000. Whereas in Canada and in countries like what we're describing, that number drops from a third down to 10% or 20%. So that means, to try to put, vague back of the envelope numbers, 20% of that, so let's say $4,000, and you can't hold me to these numbers. This is really crude arithmetic, but let's say $4,000 that family of four roughly would have to spend on a better car, to spend on a car, to spend on clothes, to spend on books, to spend on whatever it is they want. So absolutely, when you're flushing money down the toilet, as we are in healthcare today, if you stop flushing the money down the toilet, you can spend it on other things. The first rule of holes, right? Know this joke, the first rule of holes. If you find yourself in a hole, stop digging. So yes, it would be good for these other industries.
I saw one that I missed from Jeanette. Currently, Medicare defines what it thinks is medically necessary in order to get a procedure covered. This creates a coding game for healthcare providers. How will Medicare for All address this?
It's so important. This is a bigger issue in Medicare Advantage, but it's also an issue in traditional Medicare, where you're right, there's this whole upcoding game. So and by what that means is Medicare today will pay more for, major depression type 3 than it does for depression without being spent. There's all these fancy bits to how you submit your bill. It's gotten so complicated, and it's driven by the fragmentation of our system. So the biggest part of that, of course, is what happens in hospitals with hospital coding. And if you switch hospitals over to a global budget in the way I described, they can code all they want, but that's going to have nothing to do with how their global budget is determined. So this game of searching for trivial diagnoses so you can beef up your bill, that game disappears. You have the power to greatly simplify the physician fee schedule too, and make this whole game, other countries don't do this. Other countries pay their physicians at generally more or less comparable salary, income levels as they do here. Not all countries, but Canadian physicians have more or less comparable income, and none of this complexity that creates opportunity for gaming. And that actually only pays the doctor who can gain more rather than the doctor who's slugging away on the work. So you're completely right that that's a big issue, and this gives us a way forward towards fixing it. You should know that there's a movement towards fixing it without Medicare for All. So I spend some time on that as well. But you're right, it's a big deal, and I think we can fix it.
I have a question from Brian. What are the chances of getting the age of eligibility for Medicare reduced to age 60?
I don't know. Reasonable. President Biden has said he wants to do it. Vice President Harris has said she wants to do it. Most of the Democrats in Congress have said they want to do it. There's another party in Congress that doesn't quite favor it as much, but
I don't get it.
The key to making it happen is, of course, democracy. You should know that lowering the age gradually was part of the original plan in 1965. When Lyndon Johnson signed Medicare into law. The expectation at that time, it was a compromise to make it just 65 and older, and the expectation was at that time, every few years it would drop a bit so that we would get to universal coverage. It, of course, hasn't happened, but this is not a new idea. And so I think the chances are there. We should push for age 55, not 60, if we're going to do it incrementally. It very well could happen. I can't predict it, but it's possible. It's not insurmountable.
And we're really running short here on time, but I wanted to sneak in one more question from Norm. Is there a way for health insurance companies to morph their business elsewhere to preserve their stock value, like oil companies becoming energy companies? If not, what happens to the stockholders?
Not only is there the possibility, but there's, in my mind, the expectation that they would, the hope that they would, the history that they've been able to in the past. As I mentioned, with Prudential no longer being a health insurance insurer and a health insurer, but providing all sorts of other insurance. And I've never been able to find any evidence that they had significant layoffs. So, the core model of what the insurance companies does is it is transferable to these other things. The reason they don't want to do it is because we let them rip us off more in health insurance. It's so complicated and obfuscated that they can make health insurance perhaps their most, if not the most, one of their most profitable lines of business. So they want to hold on to it. But they're not going to go out of business. They're going to find a way to thrive and survive, and we want them to. So yes. So
I think that this has been a great presentation. My feeling is that we just need to go out and tell the world as consumers how good this is. And I've often posted on my Facebook page, I hate my Medicare was said by no one ever. So once you know about Medicare, and we talk about people who have Medicare, and I took care of my mother-in-law, how I got introduced with Medicare when I was much younger, and I said, oh my God, it's just easy. She sees whoever she wants, and the bills are paid, and we don't do anything. I couldn't believe it. So I think that people who really know how good Medicare is, we may just have to be doing a grassroots education, and maybe the Medicare for All people need to do that as well, because it's a phenomenal thing to be able to be on Medicare. So,
on that line,
take that idea back.
If I could make one comment on that line, everybody on the call, if you know of a venue where you would want to have this kind of discussion replicated, let me know. This is, it's so much easier on Zoom, but when we get back into face-to-face, I love nothing more than going with a meeting with a group. I've been to West Plains. I'll go anywhere, to meet with a group and have this kind of discussion. So let us know. Eager to do it.
Good. Thank you, Dennis. Thank you, Ed. This has been a great program tonight, and good luck with Medicaid, and hopefully we'll see you again, Ed, too. Thank you, everybody. Have a good night.
Thank you.
Bye now.